I haven't usually measured 125 dihydroxyvitamin D in my practice, but because it is, I understand, a fairly transient species, and it's not always consistent in the blood level like its precursor could be. But I have one patient who I asked her to take some vitamin D supplement, even not a big dose, even 1,000 mics a day, and she was made worse by it. And she came back and insisted she wanted to be tested for the 125. And her 125 level was phenomenally high. Can you explain that?
No, I can't explain that.
I can't either.
The thing with the testing the active form, the 125, I would just recommend not do it because you oftentimes it's confusing, it's hard to interpret the results, and really nobody out there is doing it in the research because if you're familiar with hormones, it's kind of like DHEA, you can measure DHEA and you can measure DHEA sulfate, and the sulfate form is kind of like the storage form of that. It's kind of like for vitamin D, the 25-hydroxy form is kind of like the storage form in the blood. The 125 form is very tightly regulated, so if they had a pretty elevated level and they were feeling bad, the symptomology goes with it, well then that kind of makes me think, well hey, was that person somebody who had a genetic polymorphism where they were creating more of that than maybe say most people would?
That was my bet.
Or lab error.
Yeah.
I have a question on vitamin D. Of course, the best way to achieve it or get it would be from the sun. You would say then
yes.
The second best way would be from supplementation or from tanning booths?
I might, you know what, I have to go to the bathroom, so I don't know the answer to that one because I think either one can be equally valid, and if you look at the patient as a whole, and like I mentioned, if it's somebody that has a fat absorption problem, well then clearly it's really probably the tanning. Supplement-wise, if you're working with a good company and you're doing a dose and you're checking it in the blood, I think they're both equally valid.
Okay, is there any credence to the idea that if you are out in the sun, that when you do go inside to not shower so you don't lose the skin's ability to absorb the vitamin D?
There may be a little bit, and if you're a furry mammal, there's probably more. So, you know, if you're like a lion, then I wouldn't recommend it, the showering afterwards. But for humans, I don't know. I've never seen a study to specifically address that, so it's really kind of hard to say.
Thank you.
I just had a question about the tanning beds too, because the light actually comes through a glass light bulb.
Yeah, if it's a tanning bed where you're getting the UVB, then you'll be making the conversion.
So it can come.
Yes.
It won't be blocked by the
right.
glass light bulb.
I had a question for Carl. Carl, I know she had one of the composites that was dissolving in the liquid. Did you, when you were doing your preliminary work with the composites, did you notice if the different composites you were working with had different curing frequencies to use for the light? Because I noticed you were using one light, but several composite manufacturers have been warning us lately that the frequency at which the composite cures the best is getting skinnier and skinnier as far as the frequency goes. Did you look at that as far as any variables affecting the way it polymerized?
No, we didn't really. I think that what I was told was the composites coming in were going to be cured, by that wavelength. And getting information out of the distributor is like pulling teeth, and so I hadn't actually gone that far. But that's a good question, and it's something I will consider.
The curing light that Carl used was my old Koch Max light, which is a halogen, so it's got all the wavelengths in it. And it had the kind of like the bare minimum spec for milliwatts. It was a 300. We calibrated it at 300 milliwatts per square centimeter, which is what the manufacturers all say is the minimum. So it's almost like it's the right wavelengths, but it's almost like adverse conditions for intensity. So, but we actually did have a good radiometer calibrated, and it was exactly 300 milliwatts.
And that particular composite, they're decomposed to some degree on 3 different occasions. When we duped in the second set, and then the first time, same thing.
I have a question for Dr. Schallenberger. Kind of questions that have been asked to us during the meeting. But as far as pathogens go and the use of ozone on those, ozone is active against viruses in most forms, as far as I know, in the different books that have been published. But what is your opinion on that? Is ozone effective against most pathogens, bacteria, virus, fungi, parasites?
Well, that give you there's a lot of answers to that question, because that's actually more than one question. Yeah, ozone itself is a gas. It's an oxidizing gas. It's going to kill every biological thing, period. It's just a question of getting the concentration on it. However, it's not common in medicine to be able to get the virus on the gas outside of an in vitro type of situation. The viruses, encode themselves in your system, so how are you going to kill that with a gas? You really can't get to that. We do have a couple of occasions where we can kill funguses, fungi on the skin. I can bag the leg and pump ozone gas in there and get it directly on there. I can shoot ozone gas into a rectum and kill a proctitis. But there aren't that many situations where you can actually get the gas in on the organism. So then the other issues become one of peroxides. And I know that the Carpendale did publish stuff on the use of peroxides on HIV, and he kills HIV at relatively, at the same kind of concentrations that we use in the blood. And basically what he did, it was an in vitro experiment, but what he did was he took cultures of HIV, and then he took serum, and he bubbled ozone gas through the serum. What you're going to get in there is a bunch of peroxides formed by that. There's actually no ozone in that serum. It's just peroxide. He then found out that at the concentrations that we use for major autotherapy, those peroxides killed the viruses in vitro. And then the third thing to consider is cytokines, and that's all Bacci's work. And this is primarily how cells go around killing and controlling viruses, is with the use of cytokines. The gamma interferon, interleukin-2, some of the major ones that you hear about. But these are the ways that the immune cells use to kill viruses and to kill the cells that keep pumping out viruses, is with cytokines. And so what Bacci showed is that you can take blood and expose it to ozone, and the polymorphonuclear cells that are in there are going to start expressing cytokines to a factor of 2, anywhere from 2 to 8 times as many cytokines as they did prior to being exposed to ozone. So I think basically when we use ozone as an antiviral, say for hepatitis C, we use it a lot for that, we're getting cytokine exposure, and we're also getting peroxide exposure.
If I can build on that, the cytokine symphony is getting very large. I think last time I checked, there are over 500 different cytokines, all doing different kinds of communication, most of them built off of either small peptides or fatty acids. But the other point that I would build on is that the first-line responder cells are dendritic cells. The dendritic cells are endothelial cells, fibroblasts, mast cells, monocytes, macrophages, polys, et cetera, Kupffer cells, lining cells of the sinusoidal cells of the spleen. We have 50 billion of them, and each of them can engulf 50 foreign invaders, 50 prions, viruses, and so forth, when they are nutritionally, energetically, biochemically competent. They have to be alkaline. They have to have antioxidants to protect them from oxidative stress. They have to have a certain stress hormone or neurochemical environment that doesn't shut them down. I think we overlook, as happens very commonly in medicine today, we overlook the primary and look at the consequential downstream results. Then we start fighting with the consequences.
And I suggest that it's also a very good idea concurrently to activate the first-line responder cells. Adequate ascorbate, buffering minerals, stress hormone adaptation. We are what we eat and drink, think, and do. If we are what we eat and drink, think, and do, we can influence that while we're doing everything else.
Dr. Herzl, I've got a question for you. On your result graphings, the initial readings, I think the 24-hour were taken at a pH of 5.35, and then the longer term were at a pH of 7.
5.81
Or 5.81.
7.0.
Okay, why is there a differential in the pH? Because what I was noticing on the 24-hour, you had a greater release and then a decrease with a higher pH.
At the neutral pH. Yeah, well, at the lower pH, you're going to have more acidic conditions, which are going to lead to the facilitation of the hydrolysis of the ester bond. So if you've got any sort of acidic conditions or basic conditions, then you're going to make the ester bond more labile for attack from water. The choice of the pHs were consulted. I don't have mine at the moment, but there was an expert in that field. San Luis.
Sam's an expert.
What do you think about the pH selection of?
We asked Sam Queen to give us some numbers as to what the range of normal saliva pH would be. And he said it doesn't get up much over 7.0 and it doesn't get much below 5.8. So we did 5.8 and 7.0. And there was more hydrolysis at the slightly more acidic pH. And that's what you were noticing on that screen.
To show you how small the world is, when I got my dissertation, one of the other fellows in the lab was a dentist named Frank Oppenheimer, and he studied salivary pH. And he found that the lowest it got under usual conditions was 5.8, and the highest it got under usual conditions was 7.0. However, he was using true saliva, which he defined as parotid saliva. And is everybody familiar with a Kirby cup? No. Okay, a Kirby cup is a little piece of plastic that fits over the parotid duct and allows you to drain pure parotid saliva into a tube, like a plastic tube you put in your shirt. And you can collect pure saliva there. He did peptide analyses, pH analyses, mineral analyses. And the bottom line is that very few people have a healthy mouth, which we all know. And therefore, the pH that you get from the mix of serosanguinous fluid that mixes with saliva can actually give you a wider range and makes the whole thing much more complicated. Now this is work that's probably so old it's not even in Google or something, but Frank Oppenheimer, if anybody is interested, this would have been 1968 to 1978 that he published what I think are the classic studies in that area. He went back to Zurich.
And we didn't want to complicate it.
Good.
I think this is a question for Dr. Jaffe. You talked about buffered vitamin C, and you didn't really talk about ascorbic acid, and you didn't say if you have any favorite kinds of buffered vitamin C, if you like the sodium ascorbate, and if you don't like, say something about actual real-life forms of, because a lot of people are taking vitamin C and they're not thinking at all about what form they're getting.
Very good question, and thank you. And I was practicing to be an absent-minded professor, which is why I got here late. Ascorbate from food is always mixed mineral ascorbate. So when we find ascorbate in food, which I think is a good model to emulate, it is always a mix of potassium, calcium, magnesium, and zinc ascorbate. I prefer that There is a triple recrystallized, fully buffered, fully reduced L-ascorbate with potassium, calcium, magnesium, and zinc, balanced so that if you need 1 gram or 100 grams, you get a healthy mineral composition. I do recommend that, in part because I'm the father of it. But more importantly, because the sodium load, if you take as much ascorbate as we think people need, based on this calibration, based on cell activity, based on plasma concentrations to optimize and so forth, the amount of ascorbate you needs, in my opinion, to be buffered, because most of the people who need it are already acidic, and if you're already acidic, ascorbic acid adding more protons to an already acidic solution doesn't make sense to me. That sounds like a problem, not a solution. So ascorbic acid is not what you find in food and not what I recommend. Sodium ascorbate is an option, but for many people the sodium load would be of concern. And while if you have good kidneys and you're really active and so forth, maybe the sodium isn't so much of a concern. What I do emphasize is 100% L form, fully reduced and fully buffered. Now you can achieve that with a sodium ascorbate, but it has to be produced under a nitrogen blanket, because if you make the ascorbate under air, the oxygen from the air will oxidize some of the ascorbate. And then you end up having to make a feature out of a dysfunction, a feature out of having diketogulonic acid oxidation products in your ascorbate, which some companies have made a marketing advantage out of a dysfunction. I don't know how they do that. So I do recommend buffered ascorbate. I recommend fully reduced all L form, just like nature, just like food. And my preference is the potassium, calcium, magnesium, zinc in balanced form. I think it tastes better because of those minerals. And the minerals are active. And that is part of my philosophy, that everything in every supplement should be known and disclosed, should be the form used by nature, the form used in outcome studies, if there are outcome studies, and should look and taste good. If it's really healthy for you, it tends to look and taste good. If it doesn't look good and it doesn't taste good, then I really would have some questions about how natural, truly natural, although the word natural has also got multiple spin meanings on it. Does that answer your question?
You also
let me just add one more thing to that,
okay.
and that is that we have one company out there who is using a buffered ascorbate form in which they're using only calcium ascorbate. And just as much of the same reasoning to not use only sodium, I would not use only calcium, and I always use the multiple ascorbates as well.
Thank you.
Point very well made. Calcium says go. Magnesium says ah. You'd like to have a balance of the two. And a sub-point, calcium ascorbate to me tastes like chalk.
That's really helpful information. And let me ask another vitamin C question. We had a presentation yesterday in a breakout session by Dr. John Wilson about OSR, and I asked John Wilson this afternoon, wouldn't it really make sense to always use Russell Jaffe's ideas about vitamin C and magnesium and zinc and on and on and on, along with OSR, and don't just take OSR, expect OSR to carry the load all by itself. Your comment on that?
No, what did John say? Did he agree or disagree?
Yeah, totally.
Oh, well, thank you. And I have I have the highest regard for John Wilson. I enjoyed his presentation. I agree that OSR, properly dosed and properly managed the way John recommended, is very promising. And thank you for saying what you said to him, because I said the same thing to him and he said the same thing to me. There is a complete philosophical synergy between what Boyd Haley is recommending, what John is doing clinically, and what I'm recommending. Complete philosophical, biological, coherent synergy. I don't know at the moment how much interactive benefit, just like we have synergy of toxicities, we can have synergy of benefits. I don't know how much synergy of benefit there'll be between the OSR and what I'm recommending. I do think it will be there. I've recommended it already to 1 or 2 people who are here at the program who happen to have autistic children that I'm trying to somewhat advise. And I'm glad you made the point, because John's presentation was on what it was, OSR, and as far as I know, it was the first presentation he'd made about it, so he should just talk about that. But I was thinking, too, What about the synergies of the other antioxidants in what is likely to be a symphony, not a solo performance? And so I was glad you asked him, and I'm glad he said the same thing.
We have a mutual admiration society here.
Not so bad. You know, when you take enough arrows, it doesn't hurt to have a hug.
Great. I have a question for Dr. Getoff, I guess. You mentioned that you would not use sunscreen usually unless you fear burning. In the sunscreen ingredients, do you have any caveats as to what to avoid and what you would recommend?
Yeah, a couple. Are we allowed to mention brands here that I have nothing to do with?
No problem.
No problem. Okay, very good. Of the numerous different companies that I found out there, so far 2 of the ones I've liked best are UV Naturals from Australia and Lavera from Germany. I know there are a couple of others, and I'm looking into a couple of others. Weleda, I would expect Weleda would probably be all right. Although I found a couple of toxins in Weleda's products, so okay. Actually, Aubrey Organics has an SPF 15, which is utilizing para-aminobenzoic acid, our B vitamin that has been given a bad name improperly, because a very small number of people were reacting to the synthetic, lousy quality PABA that was put in sunscreens in the 70s, where many of the sunscreens, Pre-Sun and a couple of others, were 100% an evaporative liquid and PABA, because the B vitamin gets into your skin cells, and it's not blocking anything. It is simply making it so that you can properly utilize the sun without having a problem. So the only one that I found that hasn't said we proudly have pulled out all the PABA, which they shouldn't really all have done, and has instead left para-aminobenzoic acid in there, but in a good quality product, is Aubrey's. And so I also like that product. But if you're putting on PABA, you can't put it on as a screen because it is not a screen. You have to apply it approximately 30 minutes before you're going out in the sun, and not apply it in the tiniest, itty-bittiest quantity you can possibly put on, and then scrape it off and stick it on the other arm, because then you're going to burn because you didn't put enough on. So there are so many different chemicals out there that we want to avoid that are in many lotions, polyethylene glycol, which is PEG, sodium lauryl sulfate, sodium lauryl sulfate, sodium lauryl sarcosinate, methylparaben, propylparaben, that it's almost easier to go over a couple brands that I like rather than having people scribble down 15 different things that shouldn't be there. Aubrey Organics has an SPF 15, which again must be applied a half an hour before you go out in the sun. UV Naturals from Australia has a very good line of 2 or 3 different products. Actually, Soleil, S-O-L-E-O or O-E is another one. And Lavera from Germany, L-E-V-R-A.
One more pearl is that selenomethionine, when taken in adequate amounts, which is about 1 milligram a day, can generally, and I can tell you from personal experience, prevent burning. I've been on a number of trips where I've gotten red like a lobster and gone to a tan without the discomfort of the pain, because the selenomethionine can pick up free radicals in the skin in that situation and prevent the oxidative damage that is the burn. Okay? The UV sets it off, but the UV doesn't. The UV has benefits too, which is activate vitamin D, mature the immune system, little things like that that actually I think are a good idea. So.
OPCs, oligomeric parenthocyanidins, pycnogenol, grapefruit seed extract, these are phenomenal to give the antioxidant requirements to the skin, which give you an SPF factor very quickly. So for example, if most people take, let's say, between 200 and 300 milligrams of a good OPC product, which could be a pycnogenol or one of the others, 45 minutes in advance is usually enough. You could go an hour if you want to. Depending on your biochemistry, you just gave yourself an SPF 4 to 6. And understand that sun protection factor, SPF, that's not a nebulous number. When it's used correctly, which is almost never, it's supposed to mean how many times what it would normally take you to start to burn, it will now take you. So if you would normally begin to burn in 20 minutes, and you got an SPF 6 that actually was an SPF 6, you just multiplied the 20 minutes by 6. So if you're not going to be out some horrendous amount of time, if I'm going to be outside for an hour and a half or 2 hours, I just take 200 or 300 milligrams of pycnogenol and don't use anything.
come up here?
I'll take the mic to her.
Yes, I had thought about also using a vitamin C compound, now I'm enlightened as to which one, a multi-mineral ascorbate, in a foundation of coconut oil or olive oil, and just putting that on the skin. How would that work?
Yes, that can work, but if you want to do that, you can just get ascorbyl palmitate, which is the vitamin C in a fat carrier form. The palmitic acid is completely natural, comes from coconut oil. And yes, you can put that in coconut oil because that comes as a powder. I would get the pharmaceutical grade. The impure grades, you have no idea what's in there. And trust me, because the definition includes how many mouse, how much rodent parts, how much bone part. Okay, so don't get the cheap stuff. Ascorbyl palmitate, pharmaceutical grade, and you can put that in coconut oil or almond oil, which is what I prefer. And that does work very well. It's not inexpensive, but it's very elegant.
I got one more vitamin C question for you. We get the liposomal form of vitamin C from Liposomal Labs out in Arizona, and they claim, of course, that you get 100% absorption, there's no GI upset, and the liposome actually becomes a part of the living cell, and it kind of targets it like a cruise missile and actually becomes a part of the cell membrane. And we give it to patients for periodontal disease and folks that we know have immune system problems. So I was wondering if you'd comment on that, if you think it's a good product.
The liposomal form is very elegant. It's about 30% ascorbate. So when you correct to an active per gram cost, the cost per gram is quite high.
Right.
The 100% availability is what you get from fully buffered, fully reduced all L form ascorbate. The company that makes the liposomes for that company says that the water that they have to use to dissolve the ascorbate to make the liposome is not free of oxygen, which to me means over time it has to oxidize. And when I asked the company what their data was on stability of ascorbate over time, they said, it's in a liposome. Now, that's the rough equivalent of saying, beats me. So I went to the company that makes the liposomes for the company that sells the liposomes, and they say it has a shelf life of about 6 months.
Okay. Because it does have to be refrigerated.
And we do have two companies out there, because LipoFlow Corporation manufactures the product, which the other company, much more recently, is now putting it in packets so that they're going out there to all the medical conferences, and they're actually selling more than the original company. But the original company, which is who I buy from, LipoFlow Corporation, it does have to be refrigerated. They give it a 6-month life. And the reason I utilize it is because I am one of the people that cannot take any form, anybody's, 500 milligrams without having an immediate loose stool within the next couple of hours, whereas I can take almost as much as I want of their product or of Gary Gordon's Vitality C, both of which for exactly whatever they're doing, getting it in better, allows me to take 4 grams 2 or 3 times a day and not have a problem.
That's one reason why our patients like it so much.
Yeah.
And this young lady wants to know what the difference between buffered C and ester C is, if it's a difference between the efficiency.
Ester C is a form of buffered C. It was the one I was mentioning when I said one well-known company is using only calcium ascorbate.
And they have the classic, but not, they have the physical chemistry, but not the biochemistry. That is, you can call calcium ascorbate an ester, but to biochemists, it's an ionic bond. It's not a true ester. So the best thing you can say is that their marketing is outstanding.
Dr. Scheffengerger, when you exercise with oxygen, is it okay to take yourself to a point of fatigue? And is it necessary to take the NADH just before you exercise or any time during the day?
Okay, 2 questions. Should you take yourself to fatigue with EWAT? And the answer would be no. That's not really the purpose. The purpose is to present more oxygen to the mitochondria. And in fact, if you're in excellent shape, which in my book means you can utilize oxygen efficiently, you don't need to do this at all. You just go out and run around the block a few times. you're going to want to do exercising with oxygen if you have an oxygen utilization problem. So, because it will gradually, as you give more and more oxygen to the mitochondria, you'll gradually induce the mitochondria to utilize it better. So actually, you start off with just a minimal amount. You don't, maybe 20 minutes once a day, and the exercise wants to be relatively light. Enough to get you so that your respiratory intake is in the order of 10, 12 liters per minute. Not much more than that, which is not going to, it's a good brisk walk kind of thing. And again, the people that are going to benefit from this are going to be people that already have poor oxygen utilization. So what would be the point in giving them huge amounts, as I've heard some people do, giving them 20 and 30 liters per minute of oxygen? They're not going to know what to do with it anyway. So I think that's the answer to your first question. Just kind of go easy with this and kind of gear yourself towards 10 to 12 liters per minute. Then the second question was about NADH. Should you take NADH? And you know, I like using NADH. I can't tell you that I have any empirical data on it, but it makes good sense to me. I am a big-time fan of niacin. Just as a clinician, over the years, I have found that when I give my patients in the order of 200 to 800 milligrams of niacin, almost across the board, they do better in almost any problem they have. And I just noticed that years before I even started studying oxygen metabolism. And of course, when you study oxygen metabolism, you realize niacin's all over the place. And if you have poor oxygen utilization, you're going to waste your niacin and you're going to become niacin depleted. If you're in a detoxifying mode, as we all are, then you're going to need a lot of niacin because you're going to need to utilize it a lot. So all my people get put on minimum 200 milligrams of niacin a day across the board, and others maybe a lot more than that. Certainly any sick people I'm working with, especially older people who I consider to have had poor oxygen utilization for many, many years, so somebody that's, say, over 60-ish, I would definitely want to put them on some NADH, say 5 to 10 milligrams a day for certainly the first 2 or 3 months that I'm using EWAT.
I have a question for the panel, whoever wants to respond. Regarding the niacin issue, using niacin, flushing, non-flushing, niacin, the amide salt of niacin, etc., comment about when any of these may be preferred.
Well, I got the microphone. I've used just about all versions. I think that niacinamide is probably the best. That's what I've seen. People can tolerate it. And for mitochondrial resuscitation, now for lowering triglycerides, that may not be true. But for mitochondrial resuscitation, I love niacinamide in the order of 500 to 1,500 milligrams. I usually like to give it at bedtime because it induces a GABA action, so it's good pre-bedtime type stuff. It also induces HGH, so it makes good sense to take it at that time. Probably the only time I'm going to use flush niacin is for my routine. I routinely give everybody 100 or 200 milligrams of flush niacin, standard niacin, a day. Other than that, if they have high triglycerides, I take that to mean they need more niacin. I've never gotten much ground off the inositol hexanicotinate.
I also use all three for various different things, and I think biochemical individuality is one of the most important things there is out there, because if a patient says that although you just switched me because I was complaining about the flushes that I was getting on regular niacin to the niacinamide, at the same dose, I don't like it. Well, we can try another dose. Well, I still don't like it. It's not giving me any of the benefits. We're going to have to go back to niacin. As far as the inositol hexanicotinate, I used to think there was no research on it showing that it would do any of the things that the other forms did until a couple of people showed me the research. So there is. I don't use it very often. And I think I'd also like to defer, although he's not here, to Abram Hoffer, who has probably done more work with niacin and the psychiatric disorders than anybody else on the planet. And he will use both. He often uses the standard flush form of niacin. Other times he uses niacinamide in very high doses. And I think that we run a grave risk every time we try to promote to people that are going to go out there and do things that something is better, because those of us that do a lot of this know that it depends on the patient.
To build on that and to cite what I think Abram would agree with, first 100 milligrams standard flush niacin, next gram niacinamide. Above that, use the hexanicotinate because it does liberate the free niacin, which does appear to improve lipids a little better. So the bottom line, I think, is all three forms, but starting with, if you need like a super B100 or something, standard flush niacin is fine. Above that, the next gram, as I said, I would use the amide, and above that I would use the hexanicotinate. Abram goes to 3 to 4 grams easily. No, he doesn't do that quickly. He will routinely go to that level, but starting at very low levels and building up very slowly. The first time I took niacin, I didn't know any better, and I took 500 milligrams, and I turned out to be a histodilic. It was one of the experiences that was both humbling and how much of a damn fool can you be kind of experience. So I don't recommend that to start off with at all. So don't rush in where angels fear to tread. The one caution I would suggest is that the sustained release niacin should not be used. It appears that the clay can get into the biliary system and cause all sorts of problems. So that is the one kind of pearl that I would share with you.
One thing I want to add to that, which I think is very important, and I always, every time niacin comes up in my classes, or for that matter, cholesterol comes up in my classes, and I'll probably be the only one feeling this way, but that's not the first time that's going to happen. And that is, I will never use niacin for any lipid-lowering reason, because I want to get at the cause, number one, and because 99% of the people that come into my office that tell me that their lipids are too high and they want me to help them lower them, their lipids are not too high. They're simply higher than the doctor that is telling them too high and that wants to put them on some statin drug believes they are. And since cholesterol is a phenomenally important substance in the body, precursor to all the sex hormones, unbelievable antioxidant, if your body believes that you should have this amount of cholesterol, or, and of course, we're also talking about triglycerides. The triglycerides are 100% diet. I have never had a person, somebody will end up showing me to be a liar next month, but I've never had a person where I can't normalize their triglycerides in a month by teaching them what they should not have been eating. And they feel so much better in so many other ways that that's an easy one. But if somebody comes in and their cholesterol level, let's just say total, is 340 or 220 or 280, the chances are that the reason their body wants their cholesterol to be that high is a combination of diet, far too many pro-oxidative substances coming into their diet and coming in from our environment, and possibly the liver not working correctly. And I will never give them a substance, whether it is red yeast rice or niacin or anything else, which is not the prime cause of their hypercholesterolemia. I will address the others and watch the cholesterol go down to where it should be for them. And if that number that it ends up leveling out at is not where their doctor wants it to be, I say, well, but it's where your body wants it to be. And I still get, even today, even though we have research studies showing that once you hit, and one study was 65, one study was 70, from then on upward, the people with the highest total cholesterol lived the longest and were the healthiest. We still have physicians taking the elderly population and putting them on cholesterol-lowering drugs. So we have a big problem.
Build on that. Cholesterol is an innocent bystander. Oxidized cholesterol can kill you. Oxidized cholesterol can be measured now in the urine by Shield Labs directly, not the antibody to it, but the direct oxidized cholesterol, oxidized LDL. The answer is they should be 0. 0 is undetectable. 8-oxoguanine is another measure of oxidative stress. It should be absent. If it's present, increase the antioxidants. And I completely agree that the blood lipids, except, and this is the one exception, David, and you've probably never seen these folks, on Tangiers Island in the Chesapeake Bay is an inbred population that was studied by Levy and Fredrickson, who developed the diet heart hypothesis. And if you've been inbred on Tangiers Island for 400 or 500 years, you too would have a defect in your cholesterol. That is unresponsive to diet, but it is the principal exception, but it was the basis for the nation's diet heart hypothesis. Oxidative stress is a big issue as it affects lipids. It's a primary issue. Cholesterol and triglycerides are innocent bystanders except to the extent that they carry oxidized products. The other two cardiovascular risk factor are homocysteine, which relates to methylation, and the value should be less than 6. And the last is oxidative stress markers or hormone distress markers, and you can get yourself so stressed that that will damage endothelial cells and induce its own kind of cardiovascular disease. So some kind of stress management slash biofeedback slash mindfulness training and so forth is the third level or the third aspect of effective cardiovascular management. This works in foxhound dogs, including the meditation, by the way. No, it works in foxhound dogs. If they're distressed, they get more disease. If they are eustressed, if they're adapted and feel safe, they have much less disease. Works in Yucatan pigs. I won't tell you how much money of your taxpayer dollars went to study that. But it is as true in people as in the animal models, Yucatan pigs and foxhound dogs.
I would also weigh in on this a little bit. I kind of agree with the statements here about not getting excited at all about cholesterol in terms of wanting to lower it. However, cholesterol, particularly triglycerides, are markers. They're markers for biological imbalances in the body, especially stress. So you do want to do things that work more at the cause. And in fact, I do think that niacin does treat the cause of high triglycerides. And no. Triglycerides get metabolized in mitochondria through the action of niacin and also carnitine. So I would suggest when you look at and you see those triglycerides are high, although it's true you can modify them with diet, and they typically indicate a bad diet, one that's got an imbalance of fatty acids. I also use that as a marker to me to tell them, you know what, I think this patient will do better with some more carnitine and certainly with some more niacin.
And to remind the choir where they are, don't forget mercury as a cardiovascular risk factor. And I wouldn't be surprised if our friend Parinandi doesn't elucidate that in great detail over the next couple of years.
Yeah, there have now been several studies, including one in the New England Journal of Medicine, that the toxic metals in the myocardium in people with accelerated vascular disease can be 50 to several hundred, sometimes several thousand times what is in the background noise of people at the same age that have no cardiovascular disease at their autopsy.
I guess that provoked quite a response, but just I hope I don't provoke quite such a long one with this next question, but I guess it's more perhaps for you, Dr. Jaffe, but others who wish to comment. The question probably is a reflection that I wasn't terribly astute during medical school when they were talking about acid-base balance in the body. But there are so many different systems we encounter about how to determine the acidity or alkalinity of the body. And I know you're attributing, to put stock in the first morning urine pH. But I know that, all of the different compartments of the body have their own unique pH, some alkaline, some acidic, and the blood is the great equalizer to either donate or to absorb hydrogen ions. And I am left rather confused about really what should we put into a salivary pH, a urine pH, whatever, blood pH, carbon dioxide level in the blood, etc. Anyone comment?
Let me start with what I think is the so-called reference standard. It is net acid excess. And this goes back to Sigard Anderson and the definition of metabolic acidosis and D.D. Van Slyke and all of that kind of stuff. So we start with net acid excess. The way laboratorians measure net acid excess is 24-hour urines collected under oil. Sue Whiting, a researcher in Canada, does that routinely. She gets college students to volunteer and she pays them and they carry jugs around and they collect their urine under oil. When we suggested, Susan Brown and I suggested to her that first morning urine pH was a very good approximation of total 24-hour net acid excess because of this equilibration phenomena as the urine sits for 6 hours in the bladder. She doubted it, but she tested it and she found that the regression is over 0.9. So the first morning urine pH does correlate very well with the net acid excess in the 24-hour urine, which as I understand it, is the gold standard for metabolic acidosis status. The net acid excess should be very modest. That gives you a first morning urine pH of 6.5 to 7.5. If you are below that, it suggests buffering mineral deficits and proton excess. We are alkaline by design, but acidic in function. We have to correct that acidic function with buffering minerals and alkaline amino acids. The issue of other specimens and other places and other values is all very relevant. If you can get real pure saliva, like this Kirby cup parotid saliva, then you will find a correlation between urine and saliva, except that the urine has an equilibration half-life of hours, and the saliva has a half-life of minutes. So the saliva can change substantially if you think about sucking on a lemon, or do suck on a lemon. Now this is with a plastic cup covering your parotid duct, so you're not in, you can put the lemon on the tongue, or you can just think about sucking on a lemon, and it changes the pH of the parotid saliva in a matter of about 45 seconds. The reason that we recommend first morning urine is because it's easy, it's consistent. Through the rest of the day, there are so many factors that influence urinary pH when you're active and out and about, maybe as many as 2 dozen. I can't make any sense out of those values. If somebody has a healthy mouth, tell me, but if you can find a healthy mouth, then I do think the saliva pH is useful, but recognize it has a shorter time constant associated with it. And I do think the metabolic acidosis is a huge issue. If you want the way to confirm that for the academic community, it would be venous pH with anion gap calculation. The standard blood gas machines today that measure arterial and venous pH can do all of the base excess or deficit, anion gap. They'll do all those calculations for you and just print it out on a form. I don't personally do venous blood gases very often. They're inconvenient and they're expensive. In the hospital, it's easy to do them. It is a good way of proving that metabolic acidosis exists for, for the one who wants hard copy data that's impeccable. It's the venous pH.
But a low CO2 in the venous blood and a high anion gap is pretty much in a metabolic acidosis situation, is it not?
Yeah, yes, yes. Yes. Now, not the CO2 you get back on a chem profile. The CO2 you get back on a chem profile is worthless because there's air in the vacutainer tube, and the CO2 actually equilibrates with that. That was something Don Young showed at NIH when I was there. So laboratorians don't pay any attention to the CO2 that you get back on the standard chem profile. If you do a venous blood gas, and you have what you just said, John, that is the definition of metabolic acidosis, you'll confirm it. You can even put them on the nomogram, the classic Seagard-Anderson nomogram, which has a very narrow, healthy range and a very wide metabolic acidosis and then compensated metabolic acidosis with respiratory alkalosis. So that plays into the issue of respiration.
Well, now, also, if a person has a very low mineral levels on their essential elements in their hair test with a high zinc, I remember some years back hearing some comment that is associated with metabolic acidosis and hypochlorhydria. Can you comment
associated? Yes, associated, statistically associated, not a predictive test for an individual patient. And the reason is, to put the minerals in the hair is an ATP energy requiring process. Many people just don't have the ATP to spare. They're in survival mode. They're not in healthy elective protective mode. In that situation, you can have almost no minerals in the hair, but it doesn't prove metabolic acidosis.
So it's more related. It's more related to ATP transport than it is absorption of the minerals through the GI tract, or what?
No.
Also
if you have enteropathy in the gut and therefore are not taking in minerals, you'll have systemic metabolic acidosis, provable in the urine, provable in the venous blood, provable in the hair. But the hair is complicated because if you're just low in ATP, you won't put minerals, even toxic minerals, in the hair.
Well, I've seen another number of patients who've had very, very low, like pan mineral deficiencies based on a hair test, and I've done Heidelberg testing on them, And they're over 60 years of age, and you'd think they'd be low, but they end up being hyperchlorhydric. Can you explain that?
Well, the hypochlorhydria...
Hyper, I said.
No, you're right. The hypochlorhydria we do understand. The hyperchlorhydria we would not intuitively understand because that should increase ionization of minerals.
Right.
There are 2 points I'd want to make. One, if you want to know about mineral status, I think the depenicillamine provocation for a non-invasive specimen getting the urine is the recommended way because you get values in the protocol for nutritional ranges on healthy people. So that I would recommend if you have a hair value that is worthy of further workup. I find the hair values on individuals very complex, very misleading at times because it's dependent on the ATP status, it's dependent on the keratin sulfhydryl pool status, it's dependent upon the oxidative stress status, it's dependent upon the hormone status. If you have a lot of cortisol and a lot of adrenaline that decreases the blood supply and says to the growing margins, hey, hold on there, we'll get back to you, and that becomes the normative state for a lot of people under stress, you won't be putting many minerals in the hair, but the hair won't be a reflection of the tissues, which is, I think, what we really want. And so that's why I do think the provocation test is worth doing. Some people like red cell minerals, but it turns out red cells are not true cells. They don't have a nucleus, and they're just some artifact. Their mineral values are some artifact. Patty Doyster spent 5 years looking at lymphocyte and red cell minerals and came to the conclusion she couldn't make any sense out of it. So I do think these are very important issues. I don't think we have by any means all the answers. I think the screening tests are very difficult to interpret. They are valid statistically. They are valid on populations, but very hard to interpret in an individual case and be predictive. It is why I like the provocative test.
Just a couple points that are worthwhile. I use pH testing with various different patients, and even though I'm not doing a specific type of saliva pH, it is a very fast and easy way of seeing somebody that is in worse condition than you think. Because the majority of the population, if they were seemingly healthy, their saliva pH, even just a standard ordinary saliva pH, not something special, should be around 7. And I see that very often, but lots of people are not. They're at 6.5 or 6, and that's a quick indicator that you've got a lot of work to do. Second thing is that if you do the first morning urine, I worked for 3 months at the Livingston Foundation Cancer Center before our economy sent them out of business, and every single cancer patient got urine, saliva, and blood pH done. And that's the first time I started seeing high urine pHs. And what the people that were over there doing this said is, oh yes, if you want to find a whole bunch of people whose urine pHs first morning are 7.5, 7.8, 8.0, 8.5, it's very easy. Just take a whole bunch of cancer patients. Why? Because their body can no longer get rid of the excess acids, which would otherwise be coming out in the urine. And so it's appearing that they've got a really high pH for beneficial reasons, but they don't. And I'll let you comment on that. And the third thing is that I had one patient that became fanatical about testing her pH. She was just testing it all the time. She calls me up one day. She says, I don't understand this, and I want you to give me a comment. Last week, I had the highest pH one morning when I woke up. And the only thing that was different was what we had for dinner that night. So I waited about a week, and we went and we had the same type of dinner. And again, my pH was a lot higher. It was 7 in the morning instead of what it normally was. And I said, what did you eat? She said, a whole bunch of sashimi. And that's exactly what should happen, but it's something people need to understand. That all the people that have told you and all the things that you've read that says, oh my goodness, don't eat animal protein, it is horrendously acidic, and it's going to cause a huge amount of acidosis in your body. The acid is caused by how difficult it is for the body to break down horrendously overcooked animal protein. And she very clearly saw the 2 days that she had raw animal protein, there was a very distinct difference in a higher pH. If you want to take pHs for urine, you should get a meter, because the second thing that's very important is the second morning pH, but you need a meter to be able to see small variations of a 10th or a 100th of a pH, because if your buffer system is working correctly, the second morning pH had darn well better be higher than the first, but it might not be, and yet it is, because you're just using a strip which is not accurate enough.
Cancer is, in many cases, a catabolic illness. And the reason that the healthy range is 6.5 to 7.5, not higher, is because catabolic illness, which causes the body to waste ammonia, whether it is acute digestion of excess protein or tearing itself down, that excess ammonia creates an artificially high urinary pH that is not recommended. Now, don't jump off a cliff about any one value. If the urine on any one morning is high, that's okay. The reason we recommend measuring it on a daily basis is so that people can compare themselves with themselves. And it has been consistently our observation that people who are more acidic are more pessimistic, they're more symptomatic, they're more hopeless. The people who are in the healthy range are more optimistic. They see opportunities instead of dangers. The catabolic illness that I didn't talk much about but is in our Alkaline Way book is very important to recognize, especially in cancer patients. So if the cancer patient comes in with a combination of metabolic acidosis, 1 foot in the fire, and catabolic illness, 1 foot on the ice, on average they're okay, but don't trust it. So if a cancer patient comes in and their pH in the morning is 7, I don't jump for joy. I want to know why. Is it too much acid being buffered by too much ammonia, and on average they're okay? I mean, you really want to look behind the crude numbers in any given clinical situation.
I'll pipe in just a little bit here. You know, about in the mid-70s, I started measuring pHs on every patient. And I did this for maybe 7 or 8 years. I measured saliva pHs, blood pHs, urine pHs, first urine pH in the morning. The only thing I could tell you was rock solid was that first urine pH in the morning. That absolutely clinically correlated with the patients and how they were doing. The saliva and the blood, I'm sure the blood was useless because I was collecting it in the wrong way, and I don't know what's up with saliva, but it's all over the place. I just never did think you could result on that, but I love that first morning pH, and you will see that change as your patient gets better and starts utilizing oxygen better, for sure.
Thank you.